stages of labor is a difficult topic for both Step 1 and Step 2. This episode should make things a whole lot easier. Please enjoy.
Hey future doctors, thanks for tuning in to Spoonful of Sugar, a podcast made for medical students by medical students to help the medicine go down. My name is Hayley Hart. I'm a student at Drexel University College of Medicine, and I will be your host today. Have you ever come across a practice question where you're asked to determine if a patient is making normal progress during labor and you have no idea where to start? I definitely had that problem while studying for my OBGYN shelf exam. I hope after listening to this episode you won't feel so lost while reading those questions. Today I'll be discussing the stages of labor. This episode will be a helpful review if you're studying for your OBGYN shelf exam or for USMLE Step 2 CK. I'll be asking questions throughout the episode and taking short pauses after each question, but feel free to pause as needed to think about your answer before continuing. Since this is only a review, don't feel discouraged if you don't know the answer. All right, let's jump right in. How many stages of labor are there? There are 3 total stages. I'll start by discussing the first stage of labor. The first stage is divided into the latent and the active phases. What happens during the latent phase of labor? The latent phase of labor is from the onset of labor to 6 centimeters of cervical dilation. Labor begins when contractions become strong and regularly spaced, about 3 to 5 minutes apart, and leading to cervical dilation. How long does the latent phase take in nulliparous and multiparous patients? The textbook answer would say that in nulliparous patients, the latent phase is less than or equal to 20 hours, and in multiparous patients, it's less than or equal to 14 hours. In reality, the latent phase of labor may take up to several days in nulliparous patients, and there is usually no cutoff as long as mom and baby are doing well. What can cause the latent phase to be prolonged? The latent phase may be prolonged with excessive sedation or hypotonic uterine contractions. A prolonged latent phase does not necessarily imply harm to the mother or fetus, like I mentioned earlier. If the latent phase is prolonged, what is the treatment? First, you can consider therapeutic rest, I've also heard this called morphine rest on my rotations, with IV analgesia. This allows the patient to get some rest while their contractions continue and strengthen and lead to cervical change. You can also consider oxytocin if the patient is having less than 3 contractions in a 10-minute period. What is oxytocin? Oxytocin is a hormone produced in the hypothalamus and released by the posterior pituitary that causes uterine contractions. Fun fact, it's also responsible for milk release after birth. For bonus points, what is oxytocin's mechanism of action? Alright, I know that one was really hard. Oxytocin activates G protein-coupled receptors, which leads to increased intracellular calcium in the uterus, leading to muscle contraction. Alright, back to the treatment for a prolonged latent phase of labor. You can also consider an amniotomy, or breaking the bag of water. This allows the fetal head to become more applied to the cervix, placing more pressure on the cervix and allowing it to dilate. Lastly, you can consider cervical ripening with a Foley balloon or misoprostol. What is misoprostol? Misoprostol is a prostaglandin agonist that leads to cervical softening and dilation. Alright, moving on to the active phase of labor. What happens during this phase? The active phase of labor is from 6 centimeters of cervical dilation to 10 centimeters or complete cervical dilation. How quickly does the cervix dilate during this phase? In nulliparous patients, the cervix dilates 1.2 centimeters per hour for a total of 4 to 6 hours, and in multiparous patients, the cervix dilates 1.5 centimeters per hour for a total of 2 to 3 hours. What can cause prolongation of the active phase? The active phase may be prolonged with cephalopelvic disproportion when the fetal head and the maternal pelvis are differing in size. How would you diagnose a prolonged active phase of labor? This is big on the board exams. So, one way to diagnose a prolonged active phase of labor is dilation of at least 6 centimeters and no change in dilation with 4 hours of adequate contractions. So this is defined as greater than 200 Montevideo units, which is measured by a tocometer, which is the monitor on the outside of the belly, or an intrauterine pressure catheter, which is placed at some point during labor. And if you forget what Montevideo units are, I'll discuss how to calculate them in just a moment. A prolonged active phase can also be diagnosed by dilation of at least 6 centimeters and no change in dilation with 6 hours of inadequate contractions, or less than 200 Montevideo units. If on an exam you're given a strip and you need to calculate the Montevideo units to determine if the active phase is prolonged, how would you calculate them? So you can start by subtracting the baseline pressure from the peak pressure of each contraction within 10 minutes and then add up those numbers. You're looking for greater than 200 or 200 Montevideo units within 10 minutes to determine that the patient has adequate contractions. Alternatively, if you're on an exam and you forget all of that, 3 contractions within 10 minutes is usually a good sign that the patient is contracting adequately. All right, let's say your patient has a prolonged active phase of labor based on the definitions we just discussed. If the active phase is prolonged, what is the treatment? So you could consider amniotomy or breaking the bag of water if it hasn't been done yet already. You can also add oxytocin to improve uterine contractions if you notice they're inadequate prior to the 4 to 6 hours and the patient is not making linear progress. Lastly, if the previous interventions were not successful, you could consider a C-section at this time. All right, let's say your patient makes it through the latent and active first phases of labor. What is the second phase of labor? The second phase of labor is from complete cervical dilation to the delivery of the infant, also known as the pushing phase. How long does this typically take in nulliparous and multiparous patients? The textbook answer would say in nulliparous patients, it's about 30 minutes to 3 hours of pushing, and in multiparous patients, it's 5 minutes to 30 minutes of pushing, although in real life, these are not always steadfast rules. What happens during the second phase of labor? So the neonate goes through the cardinal movements of delivery during the second phase of labor. Do you remember what those are? So it starts with engagement, where the fetal head enters the pelvis. Then the fetus descends into the vaginal canal. Next is flexion, where the fetal head flexes in a chin to chest direction. Then the fetus undergoes internal rotation. Then the neck extends, where the fetal head delivers. Then the fetus undergoes external rotation. This is when the fetus reconstitutes so that the shoulders are in an anterior-posterior position. And lastly is expulsion, when the shoulders are delivered. Brief but important side note, if during delivery the fetal head retracts back into the perineum, what should you be concerned for and what should you do next? So you should be concerned for shoulder dystocia. This is an obstetric emergency. First step in a shoulder dystocia is call for help. Then you can do McRoberts maneuver, which is hyperflexion of the maternal hips back towards the chest. You can also have someone that you called in for help apply suprapubic pressure. The goal of this is to lodge that shoulder underneath the pubic symphysis to allow for delivery. Also, there are some extraordinary measures that you'll read about, like breaking the fetus's clavicle to allow the shoulders to deliver. These are not usually the correct answer on the test. You should try McRoberts maneuver or suprapubic pressure first, but they always include those as an answer choice. All right, back to the second stage of labor. Why might it be prolonged? So this is usually caused by fetal malposition. On that note, what is the ideal position for the fetal head based on the position of the fontanelles? The ideal position for the fetal head is occiput anterior, or OA. This allows the fetal head to go through the vaginal canal with the smallest diameter possible. It also allows the fetus to perform those cardinal movements of delivery, such as flexion, internal rotation, extension, then external rotation. What would happen if the second phase is prolonged? So if the second phase is prolonged, i.e. the patient has been pushing for a long time, you can consider an operative vaginal delivery for an arrest of the second stage or for maternal fatigue during pushing. Operative vaginal delivery options include forceps or vacuum-assisted delivery. These are almost always performed or assisted by an attending. Lastly, if the fetal heart rate tracing is not reassuring or an operative vaginal delivery fails, you should proceed to a C-section. What is an arrest of the second stage of labor? This is defined as no change in the fetal station after 1 hour of pushing. During the second phase of labor, what is the name of a procedure that can be used to enlarge the vaginal opening? That would be an episiotomy. These are generally discouraged nowadays, and they're usually an answer choice on an exam, but they are not likely to be the correct answer. Okay, great. Let's say your patient made it through the second stage of labor and they're now having skin-to-skin time with their healthy newborn. Are we done yet? No, they're still the third stage of labor. What happens during this stage? Hint, what's still in the uterus? Delivery of the placenta, you got it. How long does this take? In both nulliparous or multiparous patients, delivery of the placenta should take anywhere from 0 to 30 minutes. Delivering the placenta is a great job for a medical student on the labor and delivery floor, but you should make sure that you do it correctly. You can place gentle traction on the umbilical cord while placing contralateral suprapubic pressure to make sure the placenta comes out in one piece. You don't want to place too much traction on the umbilical cord because that could cause cord avulsion, where the cord detaches from the placenta, or a uterine inversion, where the placenta comes out with the uterus. That would be an emergency. All right, what are the 3 cardinal signs of placental delivery? The 3 cardinal signs are a gush of blood at the vagina, lengthening of the umbilical cord, and a globular uterine fundus on palpation. What medication is usually given after delivery of the infant to help with placental delivery? That would be oxytocin. This helps the uterus continue to contract so the placenta can ultimately separate and be delivered. Administering oxytocin during the third stage of labor is sometimes referred to as active management of the third stage. After the placenta is delivered, you can visually inspect it to make sure it's intact. If cotyledons or pieces of placenta appear missing, it may be necessary to manually remove the remaining tissue or perform a curettage with suctioning. When you're visually inspecting the umbilical cord after it's been cut, what are you looking for? You're looking for a 3-vessel cord with 2 umbilical arteries and 1 umbilical vein. A good way to remember that there's 2 arteries and 1 vein is that the umbilical arteries arise from the internal iliac arteries, and there's 2 internal iliac arteries, so there should be 2 umbilical arteries as well. Some sources also say that there's a 4th stage of labor, which occurs from the delivery of the placenta to 2 hours later. This is when the patient is at highest likelihood of obstetric complications. One of these complications is a postpartum hemorrhage. What is the most common cause of a postpartum hemorrhage, and how would you determine if this is occurring? The most common cause of postpartum hemorrhage is uterine atony. On physical exam, the uterus will feel boggy and soft and above the umbilicus rather than contracted and firm at the level of the umbilicus. All right, now that we've discussed all the important points about the stages of labor, I'll transition now into a rapid review of the most important takeaways from this podcast. Feel free to pause after each question to answer. What are the stages of labor and what happens during each? The first stage is cervical dilation. It's divided into the latent phase from 0 to 6 centimeters of dilation and the active phase from 6 to 10 centimeters of dilation. The second stage of labor is from full cervical dilation to the delivery of the infant, and the third stage is the delivery of the placenta. Next question. What is the expected rate in centimeters per hour of cervical dilation during the active phase of labor? In nulliparous patients, the cervix is expected to dilate 1.2 centimeters per hour for a total of 4 to 6 hours, and in multiparous patients, the cervix is expected to dilate 1.5 centimeters per hour for a total of 2 to 3 hours. Next question, what is the most common cause of a prolonged second phase of labor? That would be cephalopelvic disproportion. And last question, what are the 3 cardinal signs of placental delivery? That would be a gush of blood at the vagina, lengthening of the umbilical cord, and a globular uterine fundus on palpation. All right, that's all I have for the stages of labor. Thanks so much for listening. If you found this episode helpful, please subscribe to our podcast. If you have any questions, comments, or concerns, visit our website at spoonfulofsugar.org and post them